So our next speaker is Dr. Soumya Ganesh. She's a cataract surgeon and a director of the Lopamudra Drishti Eye Center. She is a author and literature review of many national as well as international journals. She has been awarded many national levels and plus international levels awards. There's a long list to it. Soumya, you don't mind if I skip all of them, huh?
Absolutely.
She has been awarded ESCRS, World Ophthalmic Congress, and Asia Pacific Society, multiple international awards. And moreover, apart from that, she is a yoga instructor. So that is a feather in a crown. I really appreciate this thing, not just working, taking care of your health is really important. So I'll request Dr. Soumya to speak on pre-operative considerations and IOL selections. Dr. Soumya, please.
Thank you, sir, for your kind introduction, and also thank you for including me to be part of this IC. I'm very glad to be here amongst all of you today on this early Sunday morning, and hope it's a good one. So I'm going to be speaking on pre-operative considerations, including IOL selection. The most important part in cataract surgery, we all know, is to establish a rapport with our patient. So how this starts and how this is established really influences the whole experience that the patient has with us as, as patients, and then maybe as friends, as colleagues, as whatever. So the most important part is to make sure to make a good first impression. So the feeling the patient has while they're waiting to meet you, the ambience in your waiting room is extremely important. So we must pay attention to that. So this is the first impression that the patient gets about us, and it has to be a good one. The way the staff behaves with the patient really makes a great difference to how the patient experiences this whole process of meeting you and going back. So that has to be on spot as well. Having to wait to be seen is often a patient's number one complaint, so we must make sure we are always on time as much as possible, and it's very important to prepare our day plan and our schedule accordingly. It's very important for us to know something about the patient before the patient walks in, because that sense of familiarity goes a long way in kind of making the patient comfortable with you. It's very important to spend a lot of chair time before surgery, otherwise we'll be doing all that explaining after. So we must make sure everything is explained to the patient prior, like Dr. Soumya just told us. And also, like we discussed, when we are told a sudden diagnosis that we're not expecting, it can come as a shock. So sometimes it's good to reassure the patient about the seriousness of the condition or the treatment options available in a friendly tone, in a compassionate tone, but also very important to be formal at the same time. So I think that is something we all learn with practice. Those are soft skills that we pick up over time. But it's very important to make the patient feel comfortable and then take it forward from there. So examination, we know, is the absolute basis of our cataract surgery. It's very important to do the non-touch procedures before the touch procedures. For example, it is important we do the keratometry and topography before we do something like immersion or contact IOP testing. It's important to do a bilateral examination always. There is no compromise on that because sometimes we may miss something that can really influence the outcome. The vision must always correlate with cataract. So over the years, we've all come to some understanding about how the vision should be for a particular cataract. And if it is not falling in place, we must take that extra time to make sure we go through everything that could be influencing the surgery. And even if you do not find anything, it is important to communicate this to the patient that it is not correlating, and to let the patient know that further examinations may be needed. Examination on day of surgery is ideal, so NABH requires us to do this as well. But sometimes in busy practice we may leave it out. But ideal case scenario, we must be examining each patient on day of surgery as well. So it's very, very important to look for potential sources of infection. I think this is the most basic thing we've all done starting from our post-graduation, to look for infection sources like, we do our syringing. It's also very important to look at the general hygiene of the patient. And even if it's uncomfortable, we must address these things and communicate these things to the patient. Look out for blepharitis and meibomian gland disease. Blepharitis quite often, can hold a lot of infection load, and we must address these issues beforehand, because we don't want to be breaking our head about this if something goes wrong after surgery. And I do a syringing for 100% of my patients, so it's very, very important to look out for chronic dacrocystitis as well. Of course, I don't have to mention that there has to be a very detailed anterior segment examination, whether it's the health of the endothelium or the depth of the AC, the type of cataract. These are very important, and it must go through a stepwise format for each patient. I treat 100% of my patients for shallow angle if they have it. So I don't want to take a chance on the day of surgery, so I make sure shallow angle is handled as well prior. It's very important to look for complicated situations like posterior polar cataract, like we just discussed, so I'm not going to go into the details of that. Dry eye is becoming a very important cause of unhappy patients with time, now that we're using more and more premium IOLs, and now that the expectation of the patients are going up, and with our current modern day life, all of us, I think, have some amount of dry eye, maybe on a daily basis or occasionally. And same with our patients, they're all using digital devices. So dry eye is a part and parcel of our modern life. So we must address this before surgery. We must look out for it, treat it, also advise about post-operative dry eye and handle it accordingly. So not only does it influence our post-op outcome, it also may influence our pre-operative findings like topography or keratometry, because dry eye can change the topography to some extent. Not to miss the posterior segment, very, very important to do a dilated examination in all patients. Sometimes, if the vision doesn't correlate and you do an OCT, you will find that there is some ERM or some slight macular edema which we may miss on examination. So it's very important that all patients must be dilated, and if you're not able to see the fundus, it's very important to take a special consent saying the fundus is not visible, and then we will need to explain to the patient as well. So biometry, like I said, it is very important that this has to be bang on. Nowadays, most biometers are really good, so we're lucky in a way, and we're fortunate in a way. We're in a time where biometers are giving us such excellent results. It's very important to do our non-contact procedures prior to the contact procedures, like I already mentioned. We must look for astigmatism and treat it, and if we are not treating it, the same must be explained to the patient. And of course, until the whole examination is complete, we mustn't start talking about IOLs right in the beginning, When we're sure about the whole status of the eye, the fundus and things like that, then it is the right time to discuss about IOLs. And so, like I said, if there is some amount of astigmatism, let's say anything above minus about 0.75, we must start talking about toric IOLs, because toric IOLs are one thing that can be bang on and can give so much satisfaction to the patients. And then when we are choosing between multifocal and trifocal, of course, it's a different ball game. Now there are extended depth of focus IOLs available as well, and this has opened up our the opportunity of giving some amount of near and intermediate visions to a lot of patients who may not have been suitable for multifocal and trifocal prior. Between contact and immersion, of course, we should opt for immersion, and if an optical biometry is available, then this is even better. And of course, all myopic eyes ideally must have an optical biometry, because this checks the line of sight. Pre-operative considerations for multifocal or trifocal IOLs, apart from everything else that we've discussed, is a strong desire for the patient to be spectacle free, and an understanding about the situations that may arise, the understanding that there may be some need to use near addition. The hypercritical and demanding patients, we must always be careful and do not overpromise anything to these patients. In fact, do not overpromise anything to any patient. And of course, also explain to the patient that there can be some intraoperative situations which we may not anticipate and which may happen anyway, and then it may or may not be possible to implant a multifocal IOL. Especially in these patients, they should know. It's very important to not oversimplify the procedure. I think especially in cataract, we've come to a situation where we are selling it as a very simple procedure, but it's not, because we are, undergoing the whole stress of having to do the surgery, and we're trying to make the patient stress-free. But it's very important that the patient takes equal responsibility for the procedure and the cataract as well. For the situation, it's not something that we have created. It is a problem that the patient has. The patient has to understand that. I will never tell the patient it's a simple procedure. I will say it is an intraocular surgery. It is it is something we open up the eye to do. But because we have advanced to such a good level, we are able to do it in a very comfortable way for the patient. But it's not a simple procedure. It is a surgery, and the patient has to understand that. We put in so many years and so much money and so much effort, so much time into making sure everything is sterile, so some responsibility has to come from the patient. Once everything is over, if the patient is still unhappy, we must be able to listen to them. Sometimes they just want us to listen and to be told that we are there to help them out. Very important to document everything. If there is anything that is may cause a problem, it is very important to explain it prior and never be in a hurry to operate, and just be sure that the patient understands what is happening, you understand what is happening. I mean, in today's day and age, unless you're in training, it's better not to experiment something that we are not sure of. Pricing quite often can be a bone of contention, so this has to be very clear right from the beginning, and informed consent to protect ourselves. So I'm from Coorg. This is where I practice. You're all most welcome to visit Coorg, and have a nice Sunday. Thank you.
Thank you, Dr. Soumya. That was really precise and to